As we take the national anthem of our country, Nigeria, after count three. 1, 2, 3. Thank you very much. We may wish to be seated, please. In creating the heavens and the earth, and all that dwells within and between, the Almighty never had to consult anybody. After all, He's omnipotent, omniscient, and merciful, one whose actions are beyond being questioned. Advocacy Anchor Program, a program implemented by the Save the Children International Nigeria with the aim of supporting a conducive enabling policy environment, domestic resources mobilization, as well as strengthening accountability processes for citizens to influence health and nutrition financing through evidence-based advocacy. Distinguished guests, this meeting is planned to share the remarkable achievement, including lessons learned, challenges so far faced in the execution of this project, as well as explore sustainability options with critical stakeholders. I must sincerely welcome you to Hotel 17, Kaduna State, here for this very important occasion. Ladies and gentlemen, permit me, as I recognize here in our midst, some critical personality. The Permanent Secretary, Kaduna State Ministry of Health, they are representing the Honorable Commissioner. I welcome Dr. Aisha Abubakar Sadiq. Let's give a please word of applause. Equally, I want to announce the arrival here in our midst of the Director General, Kaduna State Contributory Health Management Agency, Kashman, Malan Abakar Hassan, Juma. You are welcome. Let's give him please a round of applause. The Bureau of Kaduna State Bureau of Statistics here represented by the Director of Corporate Relations and Social Duties, Mr. Jonah Justin Yusuf. Let's give him please a round of applause. I will roll out the roll of the protocol list in no special order. And some may be in absentia. When they come, we may wish to reintroduce them as they come. I welcome the project manager in the room, Mr. Ifedili Chukwu Ebene Idoso. Let's give him this order of applause. Sincere. The gate consultant that is here is a certified and qualified personality. Dr. David Olayeni is seated, sir. You're welcome. Welcome, ladies and gentlemen. The state team lead, Madam Tanko Mohamed Langaya, is seated in here. Other personalities that are here. Yes, we have any partners. We have from the Kaduna Maternal Accountability Mechanism, civil societies, Kaduna Nutrition in Nigeria, Kaduna Local Government Accountability Mechanism, Open Government Partnership, State Media Working Group. The representative from CAN and JNI are already here seated. Distinguished guests from the Kaduna State Planning Commission. Now we have representation equally from the Kaduna State Primary Health Care Board. Ladies and gentlemen, other partners that are here, we have LAFIA, Peace, Health Strategy Development Foundation, UNICEF, UNFPA, Alive and Thrive, MHI 360, Bill and Melinda Gates Foundation, amongst others that are here. Distinguished guests, permit me, as I am wise, for the welcome remarks and address I may wish to excuse the organizers, please. I have to reach schedules.
Through social and behavioral change communication, nutrition to address our high indices of wastage and stunting in Kaduna State. It sought to empower our citizens to improve ownership in their healthcare outcomes and access to care, and also to strengthen health systems, the foundation for their interventions at this level of healthcare, particularly their targeted interventions in the field of reproductive, maternal, child, adolescent, and elderly health, which will address our dismal indices. Kaduna State, unfortunately, has one of the highest maternal mortality rates in the world, not in the country. The country has one of the worst in the world. Kaduna has one of the worst in the country. It's not a source of pride. It's actually an indication that our healthcare system is to be improved. Now, the interventions targeted here do not only target pregnant women and women having babies. A lot of other groups have been neglected, such as adolescents and the elderly are also targeted because they are part of the behavior and the outcomes we experience. The foundation has also strengthened. The foundation has also strengthened.
Just have to stand up.
Yes.
Simple. Gates advocacy projects have been implemented to the best of our ability in Kaduna State. And so
Protocols that are not acknowledged may wish to signal so that appropriately we make the recognition, please. Thank you. And time, I go to the next round of program here, which is support with messages. Permit me as I invite from the Bill and Melinda Gates Foundation, Dr. Joseph Order, as you step up for the student message. Let's give him please for a round of applause.
The Honorable Commissioner, ably represented by the Permanent Secretary, State Ministry of Health, the Director General, Catch Madal, the State Contributory Health Management Authority, Director Planning Research and Statistics, State Ministry of Health, other directors present, partners, our able citizens, distinguished participants, good morning. I bring you greetings from the leadership of the Gates Foundation in Abuja. It's a pleasure, it's with great delight that we are witnessing this day that a grant that was given to Save the Children in 2021 is coming to a close. There's always a saying that to everything there's a time and a season. So there was a time when they had an inception meeting for the kickoff of these grants, and now they are transitioning out. They work across three broad priority areas, which the Permanent Secretary has pitched during the welcome remark on behalf of the Honorable Commissioner, touched on them. So we look forward to seeing what has been done. How has this impacted on life share in Kaduna State? Some of those key findings, achievements, and things that will fall through into the sustainability plan as they exit the system to ensure that what has been done has actually strengthened the system and will have in place the right measures and people to drive that processes. It's against this backdrop I welcome us to this event and said we look forward to hearing some of those key findings, and as we go back to our various destinations after this engagement, I wish us all a fruitful journey message back, and to our Muslim brothers and sisters, Ramadan Kareem. Thank you.
Thank you very much. The next person now is stepping up to, give the goodwill message to the state team lead of HSDF, Mr. Dr. Opolari. Sir, you're welcome, please. Let's give him please for a round. Doctor, as you step up for this part of this.
Good morning, everyone. I bring greetings from the management and all the staff at Health Management Foundation, HSDF. Just want to quickly say that. Right. Yeah, we are an organization keenly interested in how resources for health are raised and managed, both human, economic, and all the rest. And we're also keenly interested in looking at and considering what the outcomes of this project are. And I hope that at the end, Kaduna will have all of the resources necessary for its health sector to move forward, and that those resources would also be properly utilized, for the kind of health outcomes that all of us are working towards. Thank you very much.
Thank you very much. Now invited, if I call him a royalty, I'm wrong. Or he has the traditional title of the Juman Jama'a, Latun Wazir Jama'a, and the Director General of the Kaduna State Contributory Health Management Agency, Malan Abakar Hassan. Let's give him this one of applause as he step up for the good wishes.
The Honorable Commissioner of Health, ably represented by our PAPSEC, Dr. Aisha Sadiq Abubakar, the Director of Planning and other directors here present, our able partners that are here with us, other distinguished guests, ladies and gentlemen. Please allow me to stand on the already submitted objectives by the PAMSEC, Minister of Health, because her submission is the submission from what we refer to as Team Health. So on that note, I just want to wish us well, and also add that we do not see this as a closeout, but a new beginning to what will come out of what we have been able to achieve, this technical assistance given to us by Save the Children under these grants. So thank you so very much, and I wish us well.
Thank you, please. May I request the indulgence of the Permanent Secretary, the DG, and other distinguished guests here. As the program says, we shall go for tea break and group photograph. May I request that we just continue afterwards? We shall learn super. Are we? Let's clap for the honorable gentleman personality. Thank you very much. Traina, I am right for project overview. This will tell us about the project background, the goals, objectives, and target beneficiaries of this very important project. That is a gauge anchor for Closeout Dissemination meeting. It will also tell us about the project implementation strategies and key activities, challenges, and that is faced, and of course the lesson learned so far as this project is concerned. I want to invite a personality who knows it, being the project manager, Mr. Efidiluchako Ekene in Nosa. Let's give him this one of our moments.
So I want to, first of all, use this opportunity to thank all the stakeholders, all the partners, all the government representatives, everyone that have supported us in this journey. This project started, this very particular one started around April in 2021. And in the course of the project, we have collaborated with a lot of organizations, a lot of stakeholders, a lot of individuals, and there are some activities we have done in collaboration with other organizations, and there are some we led on. Next slide, just verify. So I will just try to run through the projects the name of the project is called Gates Anchor 4 Grant, and is being funded by Bill and Melinda Gates Foundation. Bill and Melinda Gates Foundation's name have changed, and they are now answering Gates Foundation. Like I said, the project started in 2021, April, and it is ending this month. The project is a health system strengthening project. In other words, the responsibility we have under this project is to advocate for the pillars, of the building blocks of the health systems. But we looked at the 7 pillars as it were, and we felt that we cannot focus on all of them, and we started prioritizing. We prioritized the healthcare financing pillar. We also prioritized the leadership and governance pillar. We prioritized community participation pillar, and then human resource for health. For us, these 4 will be the game changer if we address them properly. The money will be available, the people to deliver it will be available, the governance of the money will be there, and then we are involving the community and helping them to solve the issues, as it affects them. Yes. So I don't think this is very important, just continue. So the project, like I said, has 3 focused areas, or 3 priority areas. One is a conducive policy environment, generating sufficient financing for investing in human capital development. Of course, while we were developing this project, we were looking at what the Kaduna state government was focusing on us at that time. And the main conversation around was human capital development. How do you link human capital development to all other issues that will be happening in the state? And that was why one of our priority areas was built around this. The second one is a high-performing primary health care system that is delivering RMNCH, plus the elderly and the nutrition. You know that this is very important for people that work in primary health care environment, because that was the conversation as at that point. And so our priority was also focused in ensuring that the primary health care is responding and is performing optimally. Next slide. So our third priority is the local institutions. Like I said, we needed to ensure that the local, the CSOs are involved, the media are involved, and then the local institutions, the gatekeepers are also involved in all of this. And there are small things we did with all of these institutions, and we'll mention them as we progress. All right, so the approach we used is, there are 3 major approaches. One is public engagement and mobilization. The second one is advocacy and policy. The third one is awareness. So we did a lot of, we collaborated with a lot of organizations to mark some international days like Universal Health Coverage, like World Immunization Day, or Nutrition Week, and all of those kind of campaign periods. Those gave us opportunities to talk about specific things that affect women and children. And then in terms of advocacy and policy, there was some policy we focused on, especially regarding those areas, the healthcare financing, the human resource for health, the community participation, and what's the fourth one? So we focused in addressing, working with governments to put policy in place that will address all of those issues, especially making funding available, for the implementation of the policies. And then we had a lot of policy dialogue, engaging with government stakeholders, engaging with partners, promoting some of the issues that we feel that will address all of those issues we have said before. All right, so this is our theory of change. And like I said, all the things we did was to ensure that we achieve UHC, human capital development. So you see all the things we wanted to do and how we wanted to do them, but the ultimate objective is to ensure that the human capital development is improved, because that was the focus for Kaduna State government as at that time. That's right. So for output one, we have some sub areas where we worked on. The first one is to talk about the budget of the state, health budget of the state, and of course I forgot to mention that this project was implemented at national and at Kaduna. So there are some bit of activities we did with stakeholders in Abuja, and then but major part of it was implemented here. So we started conversation around improving health funding for Kaduna State. But what was the most important for us is ensuring effective utilization of the available fund. Because of course, we're all Nigerians. We understand what it means to advocate for increased funding in a resource-constrained economy like ours. So the country is going through a lot. And so talking about increased funding may be more challenging, but our focus was now on how to utilize that available funding. That one you have. How are you applying it? And then we also talked about full implementation of the National Health Act. There were some results we achieved in that regard. The National Health Act has a lot of provisions. Many people focus more on the basic healthcare provisions fund, but there are other areas we talked about. We collaborated with organizations to also achieve. The third one is the healthcare financing, which we supported the Kaduna State government to put in place and also developed the implementation strategy. Next slide, sir. So the second output area has 4 blocks. The first block is to have a coalition and partners that you are working with and make them strong. Build their capacity enough for them to be able to understand the issues and be able to advocate. The other block is about community participation. We recognize that before you give the community, it will be easy for the community to tell you what they need. So if you get the community involved and you are able to get what they need, so if you are supplying, if you are working with government to supply, you will be giving the community exactly what they need. And that was part of the things we felt that worked well under these grants. There are people, the CDC champions that we are put in place at the community level, and we held meetings with them, on annual basis to elicit some of those issues from them, and we made sure we did advocacy that some of those issues made it into the annual operational plan of the state. The third one is talking about the SDGs, how there are many blocks, the universal health coverage, the state, the SDGs, how the link all of these things have to improving the health landscape and all of that. So that's one of the things we worked with, more especially with the annual reports that the SDG is supposed to be developing to ensure that is focused on talking about how all the SDG goals contributes to achieving improved health for children. The final block is about Nutrition for Growth Summits. At different levels, we supported the government, even recently. We supported the national government to develop the talking points, the SMART objectives that will be presented at different during Nutrition for Growth Summits. Most times, and what we saw at the start of the grant was governments. There are big commitments that are made at different platforms that you cannot track. You understand? So these commitments are big, but when you now begin to ask yourself, how do you operationalize all of this? How do you implement this? You will see that it's very challenging and you cannot measure them. So what we are now doing with government is to develop clear, smart objectives that you can track. So if governments have agreed that they will do this, these are the things you will see to know that they are actually achieving. So that is one of the things we think we have also done well, mostly at national. Next slide. The final one is to continue conversation around one functional primary health care, primary health care per ward. Today, we now have, the new government is talking about 2 functional primary health care per ward. But at the time when we started, the conversation was about getting at least one functional primary health care per ward. To what extent the state achieved this? Of course, your stakeholders within the state will be able to tell us whether we made a lot of effort in this regard or not. But we felt that given the intensity of the advocacy and the engagement and working with partners, we felt that government made a lot of progress towards achieving this. But the conversation now is ensuring that we have at least 2 functional primary health care per ward for obvious reasons. The major challenge we have is those barriers, those delays that happen as the woman takes the child to the health facilities, that we remove those barriers. And one of these is distance to healthcare facilities. So if we remove that and ensure that a woman whose child is having challenges is able to access healthcare, at appropriate time, is a good one for all of us. The other one is the BMS code. We felt that we achieved a lot in this regard, especially ensuring that we support the state government to put the systems in place for tracking and ensuring that we understand what is happening at the community level, at the facility level regarding compliance to BMS code. At national, we also ensure that there's a technical working group, and then this technical working group are now also what we have in Kaduna have been replicated in about 27 states, and that's a good a plus for us, because Kaduna was the first state to have the technical working group, and then it's about 27 states has now taken a cue from Kaduna state government. Continue. All right, there are some few lessons that we have learned. One is establishment of community of practice. We felt that this is working well with us, or work well with us. And why we are mentioning some of these things is for some other projects to look at all of these things and see what they can pick, from this project. And that's the essence of all of this engagement. There may be things we have done well, so you can pick some of those things and then you run with them. And then child participation is another thing we feel we have done well. It is important we recognize that children have a role, to play in while we are pushing for their health. They are the ones these things are impacting. You may think they don't know. Until you engage them, you will understand that they have a good understanding of the issues that are affecting them and the way it is affecting them, and what they expect of you, either as a parent or as a government, for you to do. And then we had a lot of change agents and champions and ambassadors that we identify. And the most important one is identifying the champions within government. Many things we achieved, we didn't achieve them because we are Save the Children or because we are working with stakeholders or partners from outside. We achieved them because we identify a lot of government stakeholders who believe in positive change. And then we were able to engage with them, and some of those things was able to happen. And then we had the media working group that was very active for the 4 years that we worked. We are engaging with them, and civil society coalition, and they supported us, in the entire process. I mean, working together with them, owning the process together, and championing for the change together. Then so most of the advocacy efforts we also did was based on evidence. So we tried not to say, they said, we heard. So we tried to do some small engagement, budget analysis engagement with civil society organizations for us to have evidence for engaging with the government stakeholders. We want to run away from a point where we are saying they said, they told us, we had, you know, I mean, there can be pockets of those kind of things everywhere, but do you have the evidence to be able to engage logically? And then we believed so much in learning and sharing. There's a lot that has happened with other projects. There are a lot that has happened in Kaduna. So during our community of practice engagement, we try to learn and share amongst ourselves so that we are updating each other and then we're achieving results. There are opportunities we have identified. The first one is the new government. We saw a lot of opportunities around that. The priority, the new priority, the focus of the new government is also very important, and we saw a lot of opportunities in that. There are diverse groups and interests within the health sector. We saw a lot of opportunities in that. And then with the local government election that has happened, we have collaborated with a lot of organizations to begin to engage the local government chairman. And I think that even with the exit of this project, such engagement should continue, because if we truly want to see a change, a major part of the part of our health system has been cut and given to the local government chairman. And if we don't support them with information, support them to build their capacity, support them to understand the landscape, we may miss out. So, but if we work together to give them a lot of information, we may be helping them to achieve more. There are national, international, and global moments. I have talked about Nutrition for Growth Summit, which will be happening from the 25th of this month. For some of those of us that will be participating or that will be following online, please try to tweet and talk about some of the issues that we have put forward for government to those commitments they will be making. We feel that the CSO platform and the media working group should be sustained. They should be sustained at all costs, whatever it will cost the Kaduna stakeholders to ensure that these CSO platforms are maintained and sustained. They should do it for obvious reasons. The issues we have promoted have no end on its own. I mean, these individuals have the responsibility to continue to talk about these issues, and until they are fully resolved, we may not be flagging our flags. Then the other point is accountability networks. There are multiple accountability networks that exist in the state, most especially there's this the partners network that has been established as a result of this grant. You know, GATE grants ensures that all other people that are implementing their funding are coming together, you know, to those accountability networks should be sustained. We should not be wasting resources. We should ensure that we sustain what we have been doing so that we leverage capacity, we leverage resources, because all what we are doing is the same allergy that that owns all the cow. So we should ensure that from whatever angle we are approaching it, we are working towards the same goal. Continue. Some of the challenges we met is that affected our implementation is insecurity. There was a time assessing this road was very difficult. There was a time assessing some local government was very difficult. There was a time holding a lot of engagement was very difficult. You know, getting people together in one room was very difficult. But we thank God that some of those opportunities, some of those challenges, we've been able to overcome them. Bureaucratic bottlenecks. This is still the big masquerade that is still. This challenge has to do with all of us as individuals. You understand? Sometimes we look at the system, but we are the human beings that are within the system. So bureaucratic bottlenecks, there were times to move things around was very difficult. Navigating government offices was then very difficult, but we are happy that we made a lot of progress in that direction. Advocacy process generally is very slow. I mean, we need to understand that. It's very, very slow because it takes a lot of process. Achieving all the things we set out to achieve may be difficult for us. Maybe when the consultant will be presenting, you will see that many of the things we thought we will achieve, we didn't achieve them. It is not that we didn't attempt. We may have made, we attempted putting the systems in place, putting the structures in place, starting. But we are not able to achieve all of that. And that is why when you want to measure advocacy effort, you'll be looking at milestones, those incremental steps that we have taken, towards achieving the big objective. Once you see that we have taken those incremental steps, you can give us small mark, but it's just for us to recognize that the advocacy process is very slow because there are multiple things you need to do, before you achieve all the things you are supposed to achieve. Generating evidence and using evidence is a very big challenge. Before you get budgets, let me go back to the budgets. Before you can get budget information, is very, very challenging, as to how much has been utilized. For allocation, you can have, not in government, many people we started working with were moved, and then we started afresh again to engage them. So, I mean, it's common with government. And then even within Save the Children, we also experienced staff turnover because this is grant. People may not wait till the end before they begin to look for another work because they have families to feed, they have people that depend on them and all that. I will leave this to the consultants and then I will close because there are some things he may have found that we listed this thinking that in our own judgment that these are some of the things we achieved. But then we had an independent consultant who came around, interacted with various stakeholders. It is for you to interrogate what we have done, our own marking scheme, with what the consultant will be presenting to us later to see whether what we said we achieved, we were able to achieve them, or whether we were not able to achieve them. And if we did, to what extent. If there are areas where we didn't do well, I want to use this opportunity to apologize to the state team to say, please forgive us. But if there are areas where we have done well, please applaud us. And we didn't implement this thing as Save the Children alone. We implemented, bearing in mind that there are other networks, there are other organizations, there are other individuals, there are other stakeholders within the state that have one or two roles to play for us to achieve and get all of these things sorted out. And like I said, we effectively collaborated with a lot of organizations, a lot of individuals, a lot of stakeholders, government stakeholders, to be able to get to some of these levels. So like I said, look at all of these things and see where we have done well. I want to use this opportunity to say a very big thank you to the government stakeholders that supported us. We traveled several times with a lot of you, holding meetings, holding workshops, holding several engagements, discussing, having those hard conversations. We may not have put some of the things very well, in a way that you will be happy with them. But we didn't mean any bad. It was just for us to recognize that the person who is to gain most in all of this is that child in that community, that child, that woman in that village. So if we are working to improve their life, I think we are all doing it in good spirits. So please, like I said again, if there are areas where we have not done well, please forgive us and recognize that we are working to achieve the common goal, which is improving the health and well-being of those children, especially those ones in underserved communities. Thank you so much for all the efforts. Thank you for all the support. Thank you for all the things you have done for us. And God bless you all. Thank you so much.
Thank you very much. That has been the state team lead.
Thank you so much.
Let's give him this word
I'm
about
not the safety lead,
blessings.
but give me respect. Well done.
He said it all. They are
Yeah,
humans.
thank you.
Where they are or they cannot meet the necessary requirement, please let you make them know that this is the lacuna so that it may be filled. And of course, as a partner in progress, it is not only necessary but obligatory that the two parts come together to give the necessary cooperation, corroboration, and collaboration. Let's give it please another round of applause. The next is inviting a certified and qualified medical personnel who has spent over 45 years in his field of trades. He had a He retired from the Save the Children International in the year 2018 and is now a freelance consultant. Ladies and gentlemen, he's now a freelance consultant of nation representing Jitron Health System, these new powers. Invited to the stage, down to the rostrum, our consultant, Dr. David Olayemi. Let's give a please for our doctors as he step up for the key achievement and impact of this project.
Thank you very much, MC. My job is just to complement what Innocent has done, and there will be a few overlaps, but I try to make sure that I'm not saying exactly what he has said, or maybe I'm going to say what he has said in a different way, so that I will not be a burden to you. When I was asked to evaluate this 4-year project, I was supposed to look at it from two perspectives. What Save the Children has done, and therefore what is currently on ground as a result of the changes that Save the Children has tried to bring about. Now, of course, he has already made it very clear to us that advocacy is always a very challenging thing. If you are to go to the facilities and do some work, you can count the number of mothers that you have seen, you can count the number of children that you have seen. Advocacy doesn't do that. You are not supposed to be, you are not the one delivering the service. You are supporting government or telling government or pleading with government to do this for the children, to do that for the women, and so on and so forth. So it's a totally different kettle of fish. So my job is also therefore more complex than the usual. If we are if Save the Children was a service delivery, or this project was a service delivery project, it will probably be a totally different story. Like I said, I'm going to present it in a totally different way so that we can have another perspective. Now, this is a summary of what he presented in terms of what Save the Children through the Anchor 4 grant was expected to deliver. There were 3 areas of work. I've just tried to summarize the outcomes, the international outcomes, because the grant was actually being implemented in Nigeria, but it was also being implemented in some other countries. So Nigeria was not the only country where this particular anchor grant was implemented. It was only in Nigeria. And by the way, when Anchor 1 and Anchor 2 grants were given, they were not implemented in Kaduna. They were implemented in Gombe, Katsina, Jigawa, and Zamfara. Those 4 states. Katsina was not one of them. So Kaduna probably came in the 3rd grant, and then of course this one. So we must understand those perspectives too. So the first outcome that he presented, I summarized it by saying financing. Financing for RMNCH, RMNCAH plus N being nutrition. Well, you see, when we started, it was MNCH. And you trust us, we'll continue to build it on. I don't know when this will go to end. Because adult is not yet there. And then the aged mothers are not yet there, and so on and so forth. I hope it will be so long that we will no longer be able to pronounce it someday. The second one was accountability. To improve accountability. And the third one was policy design and implementation improved. That's a way to summarize so that you can really remember. Now, what were the results that Save the Children was expected to deliver at the national level in Nigeria and Kaduna? Number 1, annual health sector budget maintained. The idea was that, and I must say it, I've been to so many states in Nigeria. I've shared it with those in the right shop that Kaduna is, for me, different in so many ways. Different in terms of being better than many other states in many ways. Although Kaduna is also the same with other states in so many ways. And I'm not saying it because the permanent secretary is here or because I want to make you happy, or to tell you that is the truth. Because there will be a lot of truths that will also come out from my presentation, which I want us to take home so that Kaduna can be better next year. All right? The second result for Save the Children was Basic Healthcare Provision Fund implemented as provided by law. As provided by law. Please underline that. Nigeria has a knack of writing things and doing the very opposite of what has been written. And I'm sorry, Kaduna is not an exception. So, and I'm happy again that people are betting Kaduna are always ready to listen to the truth. And they don't shy away. That is what makes Kaduna different from other states. In many other states, they don't even want to hear that truth. So, that is another fact that has to be taken. The third one, under that same outcome 1, is healthcare financing policy developed. And as I'm reading, those who are the key stakeholders here will start knowing whether those ones were done or not. I can assure you that Save the Children actually heavily and effectively touched on these ones. Under accountability, government engaged on VNR. This is the voluntary review of the SDG implementation. I'm not too sure I can say that I've seen any evidence to show. I know Save the Children engaged on this, but I haven't seen any written evidence to show that it moved forward in terms of Nigeria leading others, including partners, to review what has been done with regards to SDGs. Those are areas that we can discuss when we come to discussion. Number 2 there, commitments at 2021 N4G, Nutrition for Growth, made by government of Nigeria. Again, this is about Nigeria, it's not about Save the Children, it's not about Kaduna. It was for Nigeria to make N4G commitment. Another one is happening, like he said, next week. We are hoping. Nigeria always makes commitments, but we come home and we forget those commitments. In fact, by the time the plane is landing, the commitments are gone with the people who wanted us to make commitments. We continue business as usual. Sorry, I always tell people that at my age, I cannot no longer tell it the way people want to hear it. I want to say it exactly the way I think it is. And God will really bless us, I hope. The third outcome There are two outcomes for Save the Children at the national level. One functional PHC per ward prioritized by Kaduna State. Kaduna is doing that very well. There are 255 wards and there are 255 PHCs. Very soon we'll talk about what is happening in those PHCs. Then the second one, national strategy on implementation of BMSO developed and implemented. Again, he mentioned that in his presentation, and that is exactly what it is. Whether the implementation is actually moving us forward very well or not is another issue, but certainly that outcome is there. Now, let's break it down a little. Under outcome one, Save the Children secured commitments of local government chairmen on mobilizing the community for enrollment into state insurance program. Now, this is one action that Save the Children took. Unfortunately, because it is Nigeria, local government chairmen until July last year actually did not have the type of autonomy to be able to take their commitments forward. I hope it is changing now. I hope it is going to change, and I hope it will be permanent. But that is what it is. They made some commitments, but there's a communique that they issued, which showed that they were actually geared to go. The second result there is development of CACHMA strategic communication plan was actually done. CACHMA is here. So I believe this was another result that was delivered. The third one, development of advocacy and campaign messages for CACHMA. We have quite a number of messages delivered, and I believe CACHMA is already using them. The head of CACHMA is here, and I'm sure you can confirm that. Number 4, advocated for maintenance of allocation to health at about 15% of total budget annually. Since 2017, the result that I have seen from Kaduna since 2017, the allocation was just 11 point something, 11 point whatever, less than 12%. But since that time, allocation has been about 15% or even slightly more. So only 1 year that the allocation was a little less than 15%. So Kaduna has been doing very well. If Nigeria can actually do what Kaduna is doing, Nigeria will be much better, provided the money is not just allocated or spent on health. Now, but even for Kaduna, I must say this. Allocation, yes. 15%, yes. But in terms of allocation, since between 2021 to 2023, the allocation actually started nosediving. So now you have 61% in 2021. In 2022, you have 58%. And in 2023, you have 40%. That was the expenditure, which means that even Kaduna State was allocating. But in terms of spending, the figure has been coming down. I don't know what the 2024 figure was. Somebody gave me. Maybe it was a little better than 2023, but certainly worse than 2022. I think there's something to be done. Now, Permanent Secretary, you are here. Please, even if you are going to go on your knees and beg, let this happen for health in Kaduna State. Thank you, man. Now, the last one, supported institutionalization of a strong coordination mechanism for the 3 BHCPF windows in the state. They did this, and I have it on good authority that this is happening. That when the BHCPF representative Kaduna is here, and I'm sure I can confirm that that is what is happening. Under output 2, strengthening of ACSM mechanism, that is advocacy, communication, social media mechanism, and community structures to deliver communities felt needs. This is happening very, very strongly in Kaduna State. I really believe we should clap for Kaduna for doing very well as far as this is concerned. Any government that allows the communities to have a say in governance is progressive. It's actually moving forward. I see Kaduna as a very good example and as a lesson that should be sold to other states, including my own, Kwara, where the people probably have no voice. I want to hope that that is going to change. And I'm saying it because that's what I believe is happening. If I'm wrong, then I'm wrong sincerely. I think that's one thing that we need to take forward. Strengthening of the CDC and open government partnership mechanism in the state. That's happening. Mainstreaming of community needs into state level annual operational plans. I haven't had it anywhere in Nigeria that is happening. And I believe that this is what should be maintained by the Ministry of Health in terms of making sure that people's needs are brought into. Now, I'm not saying people's needs that are not that are not based on information, but people's needs that are actually well researched and actually good for them. We need to encourage it, and we need to do exactly what they're asking us to do. Development of performance metrics with 30 indicators to report the work of TWGs annually. This is a very good one. Nigeria is a country where accountability is foreign. And I believe Kaduna State is actually leading in terms of this. This has to be kept alive. Still under two, support to accountability mechanism and institutionalization at all levels of governance in Kaduna State. Support to community using community health needs guide to mainstream needs of the community to states and operational plans. Institutionalizing of community engagement focal persons structure into accountability process at local government level. Inaugurated the TWC, that is Technical Working Committee of NAFDAC, to contribute to national report on BMS. All these are happening. NAFDAC is here, and I'm sure whether at national level only or at the Kaduna State, it's happening. And I believe that is something that we need to move forward following this meeting. The Yango Grant project builds the capacity and secured commitment of FDA chairmen on primary health care under one roof principles. Supported the state government on proper streamlining of TWGs and harmonization of AOPs in the state. Now, I understand there were about 15 TWGs about the time this project started, or maybe just before, and it's now been streamlined to 8, and which is very good. If you are really going to coordinate well, the smaller the number, the better. And then you can get reports regularly and feedback regularly. This mechanism needs to continue. The leadership of the ministry needs to encourage this one to continue. Improvement of capacity of technical working committees of NAFDAC on BMS, development of health care financing policy, which was approved by the State Council on Health. Support to Director of Health Planning Research and Statistics to conduct annual performance review of health in Kaduna State, and then development and rollout of electronic integrated supportive supervision tool, and then the ISS framework. Now, particularly this one that I've just read out is very, very important. The truth is that the local government health authority in the primary health care system is very, very important. If you allow me to say it, it's actually the most vital link in primary health care under one roof. And I will tell you why that is so. One of the problems that we have had by research, the RPC did the research, 2 researches that I helped them to do 2 times in the past 4 or 5 years. And we have discovered that Kaduna State and other states have been doing well in terms of primary health care under one roof scorecards that MPHCDA is helping them to, helping the Nigeria to do. Indeed, in 2018, Kaduna State scored 66%, which we consider low. Compared to other states, it was low. By 2019, Kaduna scored 92%, from 66 to 92%. And by 2022, the last one that was done, that scored at 6. Kaduna State scored 98%, from 66 to 92 to 98 within a period of less than 5 years. That was good, isn't it? But unfortunately, the health indices did not change. And that's a disconnect. You will expect that a state that is doing so well in terms of the scorecard assessment should also be doing well in terms of NDHS telling us that Kaduna State is progressing. That is not the case. And it's not just Kaduna State. It happens to many states. In fact, most of the states in Nigeria are in that mood. Something's wrong. It simply means that it is possible for the 9 pillars to be strong, but service delivery to remain poor. It's possible for the 9 pillars to be strong, but for service delivery to be very poor. And when that happens, the health indices will not change. In fact, the health indices can become worse. That is one message that the permanent secretary and others who are senior leaders in the Ministry of Health needs to really take home. Something has to be done. Questions have to be asked, and answers have to be gotten as far as those areas are concerned. So, and I say that the local government health authority is the most significant link between the primary health care board and the health facilities. How much, first of all, what is the quality in the local government health authority? Personnel, the type of support they have, the transportation, the type of facilities that they have to be able to support the facilities. They are the ones who are supposed to go to the facilities to check what is happening facility by facility. So it's possible for us to have 10 primary health care centers in the local government. If they are not being visited and supported by the local government health authority, it will not happen. The second one is that the local government health authority is also the link between curative care and public health, which means that is a very, very critical link. Unfortunately, Nigeria in most of the states has not got it right. Kaduna can be one of the first in getting it right, in terms of making sure that government does something about every local government authority to become very, very strong. Very, very strong. Strong to the extent that authority is decentralized from the center to them. We move on. Now, I said Kaduna is a very lucky state. There are 5 reasons why I can confidently say that after this evaluation. Number 1, we have a governor who is ready to listen. I don't know him. I have never spoken to him. What I have read in the papers is what I have this one there. If you know him and you think that is wrong, please pardon me. But that is my impression. The second reason is that public servants that I have met, whether in Kaduna or in PHCB or in Federal and State Ministry of Health or anywhere, I see them as they are ready for the change. Again, I've met you only a few days. If my assumption is wrong, then please pardon me. I'm a human being after all. The third one is that CSOs and communities are ready to be part of the change. That one, I have no apology, because I know that is the case. I've interacted very well with them, both as CSOs and as ward leaders, and I know they are ready. And I think that is one area, again, we need to clap, because Kaduna is a leader. The fourth one, thank you for clapping. The fourth one, we have partners who are ready to support. I have met a number of them. Again, I'm not holding an apology here, because I believe that is the case. They are ready to support. Maybe their support is very, very small. Usually, support will always be small. It cannot be big. Otherwise, they take over. So that little support can actually help Kaduna State to do much more. And we need to take advantage of that. Lastly, we have a media that understands challenges and are ready to help. For the first time in my career, I've met some media people who were in the program from the beginning and they stayed until the very end. I don't know where that happens. I haven't seen it. And again, pardon me if I'm wrong, but certainly in this particular case, I think I can beat my chest and say that is what I've seen in Kaduna. These five, if we take advantage of these 5, then I'm sure Kaduna can actually be the state that every state will come and learn from in a few years. Now, we now go, I want now to take you to where I have a problem. The next few slides will show where I have a problem. Number one, we must always ask ourselves, why should government be involved in health care delivery? Why can't government just say private people continue to give health? If we do that, there will be a lot of problems. There are three reasons why government is involved in health. And these are the three reasons. One, to take care of externalities. This is the World Bank view. To take care of externalities. Number two, health is a public good. And number three, equity. There is no private organization that will ever give us equity. They are not interested. Private people are not interested in equity. I hope you understand that. I will see the definition of equity and why private will never be involved in it. Taking care of externalities means that there are certain things that government needs to take care of because no other person will do it. And government has the money and our resources to do it. So taking care of externalities is part of what government is going to do. And there are many externalities that that must be taken care of in health. Then health is a public good. If anybody would try to find out what is happening, the information that is required to work in health in Kaduna State is government. No other private individual will do it for the fun of it. Government has to do it. If there's an outbreak somewhere, government has to be the one to go there. The information from that is what government needs to share and make sure that everybody has information and is able to take care of himself or herself. So government has to be involved. Then lastly, equity. Many of us use that word. How much of it do we really understand? We will see whether we understand it or not shortly. Now, okay. Then, what does the health facilities? Why are they there? What are they supposed to be doing? The goals are just three, as far as the World Bank Institute is concerned. Improve health outcomes. That's number one. Number two, they are supposed to source for money to be able to do this, and then they are supposed to satisfy the public in terms of the delivery of health service. We must start asking ourselves, are these goals really our goals in Kaduna State? We must ask ourselves if that is actually the case. Now, coming back to how Kaduna is funding or funding healthcare. My interaction with Kaduna shows that every family of 6, husband, wife, and 4 children, will pay 57,000 something, close to 60,000 per annum. I'm sure the DG Kaduna is here and is agreeing with me. And then the individual will pay about 10,000 naira. What I have discovered is that Kaduna has about according to Bureau of Statistics, close to 70% of the citizens are either unemployed or underemployed. Indeed, it's 40-something percent unemployed and 20-something percent underemployed. If you add it together, it comes to 69.9%. Either unemployed or underemployed. That's about 70%. Now, when you have 70% that are either unemployed or underemployed, it simply means that you cannot ask them to pay anything close to what we are asking. You can't. If we are doing it and they are not enrolling, many of them don't even know about this concept. And those who know, even if they want to enroll, they cannot enroll because something to come from their pocket to enroll is not there. And there's no amount of campaign that will get the money out. I'm sorry, that is the bare truth. When poverty is this big, it's really big. When poverty is this big, there is no way you can get the informal sector to enroll. And I can see the sweat of Madam Suleiman and others on this. They are actually lamenting that in spite of all the efforts, they are not enrolling. I'm sorry. They are not enrolling not because they don't like your face, but because they don't have the money. And the little money you're asking them to, now how will a very poor man bring together 60,000 naira in order to enroll for service that he or she does not need yet? Because that's what it means. So there must be a rethinking about, now if you look at 30 countries, what I've done here is to bring 30, again, this is from World Bank and Institute. This is from 30 countries. And what you will see is that the blue bars, country by country, represent what the government is putting in order to get people to enroll. The blue represents, so this country does not put anything at all. It allows France does not put in any, very minimal what they are putting in. But from that, the second one onto here shows you those who are the government that are actually putting in money in order for people to enroll. And they are doing it on the basis of equity. Now, what is equity? It's a word we all love to use, but it's a word that many of us probably don't even understand enough. In health, equity means that everybody will get quality health on the basis of need and pay for it on the basis of means. In other words, everybody will get the same quality of health, irrespective of how well they are able to pay. But they will only pay what they can pay. It means there must be a very good assessment in place for the community, so that the family, or your own family, because you have a big means, and the DG who is also a big man, has big means, can pay. Therefore, it's going to pay the maximum. But my family that is very poor may pay only 10% of what the DG is paying, because that is what my means can afford. But we are going to get the same. The question now is that what we are practicing in Kaduna? That is what every children wants Kaduna to do. But we are not yet there. And you will see that the countries that are here are the most progressive in terms of our universal health coverage. And the ones that are here are the least progressive in terms of universal health coverage. Now, the good news is that if government is doing it well, the number of families that will now be depending on government will become less and less as the years go by. Because one, they are not being impoverished by paying for health. Because health is very impoverishing. Sickness is very impoverishing. One member of the family that falls sick can consume the whole that the family is having, and they become poorer. But if the government can take it off most of the families, it simply means that the families will not be able to thrive. And then as they become richer and richer, government will now be freed from supporting them. And you may tell me that it's theoretical and that in Nigeria that will not work. My question will be, why is it working in other places? And so why would it not work in Nigeria? I think it's something that we need to think about. And I will say a little more about it as more progressive. Now, what I have done here is to show us, unfortunately, it cannot be better than this, because I think I can make it a bit better. I have tried to place Kaduna State primary health care system in this circle and surrounded them by the environment that needs to help them to thrive. Primary health care can only become better if all these leaders, government functionaries, our leaders, governor, the permanent secretary, commissioner, and all that, if they would take the right decisions, I'm sorry, and I'm not saying you are taking the wrong decisions, but I'm saying in terms of what we have said now, if they would do that, they will help primary health care to thrive, and then the competitors will make sure that we also make sure that the competitors are also spoken to, that for a time they can let go and let the primary health care survive and survive well. And then the partners who are here can also help them to do what they have to do over time, and they get better results. And then all the bystanders, the CSOs, the community who are beneficiaries, and even the opponents who are here will also support to make sure that the primary health care board is surviving. Now, there are 10 things that are put here. I wish I could make it larger so that we can quickly read through them. Okay, I think it's better now. Now, there are 10 things that are in the environment that will make it very difficult. Number one, pervading poverty in Kaduna State. I've already spoken to that. About 70% is very high. It's one of the highest in Nigeria. Maybe Sokoto is the worst, but Kaduna is certainly not too far. Poor implementation of extant laws and policies, and I say that because with all humility, and permanent secretary is here, that is one area I know we need to carry advocacy to the governor. There are certain payments that, I'm sorry, this is an open forum, I should be able to say Kaduna is very open. There are a number of things that are in the law that I have looked at, where government is supposed to be making some payments, but it's not happening. I think those areas, it is necessary for us to carry advocacy to the governor. Maybe he doesn't know. And it would certainly ensure that the work of Katima will not be as easy as it should be. In terms of 1% deduction from the consolidated revenue, and in terms of payments for the counterpart payments for workers. Those monies need to get to Katima on time and continuously. Katima has not met me to advocate for them, but I'm doing this free of advocacy, hoping that it's going to help to change the narrative somewhat. Number three, poor accountability by public duty bearers, poorly maintained infrastructure all over the state, rigid cultural beliefs and practices, poor motivation of health workforce, internal and external health workforce migration, insecurity, illiteracy, particularly of mothers, and then lastly, low labor force participation, especially among women. These are some of the environmental issues that I believe needs to change if we are really going to move forward. Now, I have put this diagram here so that we can see another area that needs to change. Kaduna is one of the, actually Kaduna is one of the 36+1 states in Nigeria where HCD is an ambition. UHC is being implemented, and HCD is an ambition. But we can ask ourselves questions since 2017, 2018, when HCD was launched in Nigeria, and now, that's about how many years? 7, 8 years. What has changed? One of the reasons why it's not likely to change is what I have put in the middle here. There is supposed to be collaboration between universal health coverage and universal basic education. If you look at WHO framework, the WHO framework is very ambitious on health workforce. What they have done is to have a, I'm going to show it. Let me see if I have it. Oh, no, I don't. Okay. I have the framework, and we need to see that. Okay, thank you. We need to see that framework. The framework shows that the cohorts of children from universal basic education level, they will follow the cohorts. Those children who want to follow health profession, those who want to follow engineering, those who want to follow this and that, they would have been disaggregated right from the beginning. And the education will help them to develop along the lines they have chosen. They will do everything deliberately to make them, tailor them to meet those things. So those who will be in health will continue to be prepared towards that direction. Those who will be doctors, those who will be nurses, those who will be midwives, and so on, will be prepared deliberately. The state is interested. And they are doing it along with health to be able to get there. That's planning together. In a situation where most of our sectors work in silos, it's a very big problem. I saw Kaduna alone. I don't know whether on please correct me if I'm wrong. whether Ministry of Education in Kaduna and Ministry of Health, apart from meeting under the Deputy Governor, whether they have any collaborative planning meeting where they are planning the future of the children to be able to develop in these directions. If it's not happening, when is it going to start? That is what WHO expects, and that is not what we are doing. And then, of course, that is the only way we can have the type of labor force that is envisaged under HCD. And that is what HCD is all about. It means right from the beginning, we are preparing our children for the type of professions they want to be, including health. That has to be deliberate. It has to be intentional. Now, WHO says there is no health without a workforce. If the workforce in Kaduna State is poor, we cannot expect the service delivery to be better. Then, there is no HCD, sorry, no UHC without equity. If we don't practice equity the way I have explained, then enrollment will remain poor. That is a basic fact. And it's not David Olayemi that is saying it, it is the truth. Number 3, there is no HCD without effective and sustained collaboration between Ministry of Education and Ministry of Health. Then lastly, so what are the next steps for Kaduna State? We know the problems. We know the problems. What are we going to do from tomorrow? This is a close-out meeting, but the close-out meeting is supposed to push us into now deciding, as an individual, as organizations, what are we going to be doing differently from tomorrow? Which of these problems are we going to solve? And how are we going to solve them? Who are we going to meet? Who are we going to take the messages to? These are the things that we need to decide. Remember, vulnerability is defined in the dictionary. Whatever other definition you have, different from this one, will not be acceptable by me. And you may ask yourself, are you an authority? And I will say, no. This is the dictionary definition. And I like this one. It says, it means a person in need of special care, support, or protection because of age, disability, or risk of abuse or neglect. 70% of people in Kaduna State are in this category. And this is what we are supposed to face. And this is what equity is. Equity is different from equality. You can see equality, all of them are on the same platform. Just like we're asking all of enrollees to pay same amount. That's equality. If you do that, they will all be struggling. This one will be able to catch the fruit. This one in the middle has been given the same platform, will not be able to catch it. This one cannot even reach it. This one, maybe if he jumps up, that is if he steals money from somewhere, they'll be able to get there. But we are not asking them to steal. Now, this one cannot even get there because it's so short. It's as tall as myself. All right? Now, but if you look here, they are giving different platforms. So this one who is tall is given a shorter one. This one short, very tall because of poverty. Is given, very, very short because of poverty. Is giving a bigger support. This one is giving less support because it's certainly taller than this one. And this one is very tall, giving just a small support. That is the only way the three of them can catch the same fruit. This is what equity is. I thank you very much. What we are supposed to do is to spend about 10 minutes in groups to really pick one of these areas, one of these messages, and see what we need to do, what Kaduna State government needs to do differently, and who should be the advocate on that. I will now hand over back to Save the Children or to the MC.
Thank you.
Because we have to discuss. Thank you very much.
Thank you. Let's clap for him, ladies and gentlemen. Well, I just realized some of us are not from Kaduna State. I want to most sincerely welcome you to Kaduna State once again. As the name implies, Kaduna, it derived its name from the word crocodile. Kada in Hausa is crocodile. Kaduna is a plural form of Kada. So Kada is crocodile, Kaduna means crocodile. Let's clap for Kaduna State, please. As for my father, the consultant, later in the day, you may wish to visit Kaduna River, and some of you who are new to Kaduna, our crocodiles are very, very friendly. You can have a selfie with them so that you know. Let's clap for Kaduna State, ladies and gentlemen, and the crocodile there, ladies and gentlemen. Well, it's time. I commend the presenter, the consultant. His point, his presentation were quite lucid and straight to the point, and they needn't any pontification or elucidation. Thank you very much, sir. The permanent secretary, distinguished guest, we now introduce something that will remain indelible in the mind of all of us. We call it photo session, and the time is now. I request the indulgence of the secretariat. You move so that we have it behind the banner. The official photographer, may we ask your indulgence to please step up so that we have this moment that will remain indelible in the mind of all of us. I'm sure we pick a picture to reminisce what transpired here today at 717 Hotel Yakubuga. The Honorable Commissioner here, all the table there, please may we ask your indulgence, your table equally. The Secretariat, all the Secretariat, please. Or maybe I should mention names. Yeah, we are requesting you indulgence, ma. It's time for photo session. Kaduna Maternal Accountability Mechanism, Civil Society Skilling of Nutrition in Nigeria, Kaduna Local Government Accountability Mechanism, Open Government Partnership, State Media Working Group, CAN and JNI, all are expected to come in here. Latvia, Place, Health Strategy Development Foundation, UNICEF, UNFPI, Alive Must Thrive, FHI 360, Bill and Melinda Gates Foundation, among others, to please. The DG, all of you, please. The permanent secretary is here. The consultant, it's a moment you ought to be here. The project on all of you, please. Yeah, the PS is coming out now. The consultant, sir. Okay. Can you help us, please? The state secretariat should be behind. Please, all of you that I call Nigerian nurses and midwives, NAFDA, all of you, please. Those mentioned, we have seen you seated. The media, I call you to